Hello and welcome to this learning video. In this session, we're going to discuss the assessment and management of medical emergencies in older adults. This video is designed to supplement any readings or coursework assigned by your instructor. Polypharmacy is commonly defined as the regular use of 5 or more medications simultaneously. This is a prevalent and complex issue in adults over age 65. The high incidence is driven by the management of multiple chronic conditions like hypertension, diabetes, and arthritis, leading to prescriptions from various healthcare providers that may not be centrally coordinated. While intended to treat specific ailments and improve quality of life, the increased number of medications can significantly increase the risk of adverse health outcomes. Consequences include higher risk of adverse drug reactions, reduced medication adherence from complex medical regimens, increased potential for falls and cognitive impairment, and drug-to-drug interactions that can diminish the effectiveness of treatments or cause new health problems. When obtaining our sample history, be sure to obtain a thorough medical history as well as a detailed list of all medications. This includes prescription medications, over-the-counter meds, vitamins, and supplements. While many believe that over-the-counter medications and vitamin supplements cannot be dangerous, they can interact with other medications and alcohol. Be sure to document this information and pass along to the emergency department staff. Medication noncompliance is also a concern in the elderly because of financial challenges, difficulty opening containers, confusion, and impaired vision. Calls for older adults with chest pain are a common EMS call and can often be caused by cardiac issues, including an MI. We need to recognize that older adults often do not experience the classic chest pain that's characteristic of heart attacks in younger populations. Key assessment considerations involve observation for silent or non-traditional symptoms, including sudden onset of shortness of breath, unusual fatigue, new onset of confusion, or unexplained falls and syncope. Other subtle presentations may include autonomic symptoms such as nausea, vomiting, cold sweats, or feeling lightheaded or dizzy. If we suspect a patient is having an acute cardiac event, such as an MI, we will treat them as we would any other patient. We would evaluate ABCs, administer oxygen if it is warranted, and consider administration of aspirin and nitroglycerin. Be sure to obtain a thorough medical history and carefully evaluate the patient's entire list of medications to determine whether they have taken any erectile dysfunction medications in the past 24 to 48 hours. Patients should be transported to an appropriate cardiac facility with ALS if they're available. Younger patients with heart failure often have heart failure with reduced ejection fraction, which is typically caused by coronary artery disease. In contrast, most older patients have heart failure with preserved ejection fraction, where the heart muscle is stiff and cannot relax or fill properly with blood. This happens even though the pumping function remains normal. This is linked to age-related changes like vascular stiffness and left ventricular hypertrophy, often driven by long-term hypertension. Traditional heart failure symptoms like dyspnea and leg swelling may be present but are often less prominent or can be incorrectly attributed to other conditions like obesity or lung disease. Older adults may present with atypical symptoms including confusion, delirium, extreme fatigue, weakness, loss of appetite, or reduced physical activity. Remember with right heart failure that the fluid backs up into the body, and that is why we see signs and symptoms including jugular vein distension, ascites in the abdomen, and peripheral edema in the hands, feet, and ankles. Conversely, left heart failure causes the fluid to back up into the lungs, causing pulmonary edema, dyspnea, and wet crackles in the lungs. Treatment for older adults with heart failure includes oxygen administration, proper positioning, CPAP according to local protocol, advanced life support care, and prompt transport. Remember that in severe cases of pulmonary edema, CPAP may be ineffective and manual bag mask ventilation may be required. Geriatric considerations for stroke include managing common risk factors like hypertension, atrial fibrillation, and diabetes, which are often complicated by polypharmacy and other health issues. Following a stroke, elderly patients face a higher risk of mortality, poorer functional outcomes, and prolonged hospital stays requiring comprehensive and prolonged rehabilitation, including physical and speech therapy, to address potential long-term disabilities. Early recognition of stroke symptoms and prompt treatment and transport are critical to minimizing disability. Remember that using the Cincinnati Stroke Scale, using the FAST acronym, to evaluate facial droop, arm drift, and slurred speech is a quick and effective way to evaluate a patient for stroke. Also remember that many hospitals prefer the use of a more detailed stroke score, such as the RACE stroke score seen here. This can be completed during transport to a stroke center. Neurocognitive disorders are a group of conditions that affect brain function, leading to changes in cognitive abilities such as memory, attention, language, and reasoning. Common in older adults, these conditions are categorized as mild neurocognitive disorder, where individuals remain independent in their daily tasks, and major neurocognitive disorder, formerly called dementia, which involves significant cognitive decline that interferes with their activities of daily living. The most common form of neurocognitive disorder is Alzheimer's disease, which is characterized by a gradual and progressive decline in memory and learning. This often starts subtly and gradually worsens over time. As the disease progresses, individuals have trouble with language, reasoning, and planning, and they may also exhibit significant personality changes. Parkinson's disease is a progressive neurologic disorder that affects movement, balance, and coordination. It is caused by the gradual loss of dopamine-producing nerve cells in the brain. A significant percentage of individuals with this condition will eventually develop Parkinson's disease dementia years after the onset of their motor symptoms. Another type of neurocognitive disorder is Lewy body dementia, which often features early and prominent cognitive fluctuations, visual hallucinations, and some of the other features of Parkinson's disease, including rigidity, tremor, and slow movement. The cognitive decline in Lewy body dementia may initially resemble Alzheimer's, but it's the presence of these distinctive motor and hallucinatory symptoms that help differentiate it. The bottom image here illustrates changes in the brain of a patient with Alzheimer's disease when compared to a non-affected brain, shown at the top. Notice the shrinkage of the cerebral cortex, the enlarged ventricles, and the shrinking of the hippocampus. Delirium is defined as an acute change in mental status, attention, and awareness that develops over a short period and tends to fluctuate in severity throughout the day. Often described as an acute confusional state, it is not a disease itself, but a symptom of an underlying medical condition. This can include urinary tract infection, dehydration, severe pain, or an adverse medication reaction. Unlike the gradual cognitive decline seen in dementia, delirium is sudden onset and is often reversible if the root cause is identified and treated. Symptoms of delirium vary widely and can include difficulty focusing, disorganized thinking, memory problems, disorientation, hallucinations, delusions, and emotional disturbances like anger or fear. It can manifest itself as agitation or restlessness, or with lethargy and withdrawal, or it could be a combination of both. Older adults are particularly vulnerable to developing delirium, and its occurrence is associated usually with poor outcomes, including longer hospital stays, increased risk of injury from falls, functional decline, and higher mortality rates. Prehospital management depends upon your assessment findings. Problems with hypoxia, hypovolemia, hypoglycemia, and hypothermia can be treated in the field with BLS and ALS care. When evaluating an older adult who experienced a syncopal episode or fainting spell, we should be concerned that the episode was caused by a potentially life-threatening problem. Earlier in the course, we talked about non-critical causes of psychogenic shock, including vasovagal syncope, anxiety, and emotional stress. With older adults, however, we need to be more concerned about life-threatening causes, including dysrhythmias, heart attack, vascular changes, volume loss, medication reactions, and neurologic causes such as TIA and stroke. Treatment will be based on the patient's complaint and our assessment findings. Advanced life support should be called for syncope involving older adults. Peripheral neuropathy refers to any condition that affects the nerves outside the central nervous system. Neuropathy can be caused by diabetes, alcohol abuse, vitamin deficiencies, and autoimmune disorders like rheumatoid arthritis and lupus. Causes may also include kidney disease, thyroid disease, and menopause. Neuropathy can affect sensory, motor, and autonomic nerves, each manifesting with distinct symptoms and challenges. Sensory neuropathy is a common presentation leading to symptoms like numbness, tingling, or burning pain, typically in the feet and hands. This loss of sensation increases the risk of undetected injuries, infections, and falls, as older adults may not feel pain or changes in temperature. Motor neuropathy impacts muscle function, resulting in muscle weakness, cramping, atrophy, and gait disturbances. This decline significantly affects mobility, balance, and independence, making tasks like walking or climbing the stairs difficult and increasing the likelihood of falls and immobility. Lastly, autonomic neuropathy involves damage to the nerves controlling involuntary functions such as our heart rate, blood pressure, digestion, and bladder control. Symptoms can include orthostatic hypotension, urinary incontinence, and constipation. Potentially life-threatening issues including dysrhythmias or impaired awareness of hypoglycemia in patients with diabetes can also occur. Depression in geriatric patients is a serious medical condition and is not a normal part of aging. It is underdiagnosed because older adults may present with physical symptoms like fatigue, chronic pain, or memory problems rather than typical mood-related complaints. Furthermore, symptoms can overlap with or be masked by other medical illnesses and cognitive decline, making an accurate diagnosis challenging. While many older adults face significant life changes such as retirement, loss of loved ones, or declining health, persistent feelings of sadness, hopelessness, loss of interest in hobbies, and withdrawal are key indicators of a depressive order. The risk of suicide is significantly higher in the geriatric population when compared to younger groups, with older white males having the highest rates. The reasons are complex and often involve a combination of factors including untreated depression, social isolation, loss of independence, chronic physical pain, and the presence of terminal illness. A key concern is that older adults are more likely to use highly lethal methods and often provide fewer warnings than younger individuals, making our preventative efforts critically important. When evaluating a patient who is displaying signs of depression, it is appropriate to ask whether they are considering suicide. If they answer yes, then we need to ask them whether they have a plan. Please be sure to share this information in your written documentation and share it with the emergency department staff. The American Geriatric Society, in partnership with the National Association of EMTs, uses the GEMS diamond as an acronym for Comprehensive Patient Approach to Geriatric Patient Assessment in EMS. These four components are G, which stands for geriatric, which involves recognizing the unique characteristics and complexities of older patients. E stands for our environmental assessment, which focuses on evaluating the patient's living conditions for potential safety hazards. M stands for medical assessment, which requires a thorough review of the patient's history and current medical issues. And S, which stands for social assessment, which considers the patient's social circumstances and support systems. This holistic approach helps EMS practitioners provide tailored care that goes beyond the immediate medical emergency. During the environmental assessment, the EMT should conduct a brief evaluation of the surroundings, noting the general condition of the home, checking for clutter or broken fixtures that could be trip hazards, and observing for any other safety hazards. For example, is the home too hot in the summer or too cold during the winter months? Or are there loose throw rugs that could become a trip hazard? Documenting these observations helps the medical team at the hospital to better understand potential contributing factors to the patient's condition, and it also ensures proper follow-up prior to patient discharge. During the social assessment, the EMT should discreetly attempt to gather information about who lives with the patient, whether there's a caregiver that's present, and whether the patient has a reliable social network of family or friends. The EMT should also look for signs of potential elder abuse or neglect, including things like unexplained injuries, poor hygiene, or unkept living conditions. Lastly, does it look like the patient needs assistance with the activities of daily living? By addressing these social factors, the EMT helps ensure that the patient's overall well-being and long-term care needs are going to be considered. As older patients live longer, more terminally ill patients are choosing to die at home rather than at the hospital. Dying patients can receive palliative care at home, in the hospital, or at a separate facility like a hospice house. Palliative care recognizes that death is a normal part of the life cycle and focuses on relieving pain and providing emotional support and comfort to the patient and their loved ones. Hospice is a specific type of palliative care focused on quality of life, dignity, and comfort for people with a terminal illness, typically with a life expectancy of 6 months or less. Hospice support is often utilized by patients choosing to die in their home and is covered by Medicare and other health insurance. If you remember back to the medical legal module, we discussed the difference between do not resuscitate, or DNR orders, and physician orders for scope of treatment, or POST documents. Samples of these documents are seen here on the slide. Remember that a do not resuscitate order does not mean we do not treat the patient. If the patient requires transport, we will provide all appropriate care up to the point where they arrest. Remember to bring the original DNR or POST form with the patient to the emergency department. Skilled nursing facilities, also called nursing homes or long-term care facilities, provide 24-hour care for patients who are unable to care for themselves at home. These facilities may also be an interim stop for rehabilitation services between hospital discharge and being able to return to their homes. While there may be a handful of registered nurses at the skilled nursing facility, most of the providers we will encounter are licensed practical nurses or certified nursing assistants. It's important to know who you are taking a report from. Assisted living facilities are another type of long-term care facility that helps patients with activities of daily living. This includes getting dressed, bathing, and medication administration. Some assisted living facilities specialize in Alzheimer's disease and care of other neurocognitive disorders. When responding to a nursing home, it's important to speak with the caregiver who usually works with this patient so that we can determine their normal baseline and whether they've noticed any recent changes. The facility should also provide EMS with transfer paperwork that should be transported with the patient to the emergency department. This paperwork will contain a summary of the patient's history, medications, allergies, and any other information that's pertinent to their transfer, and we should review this prior to initiating transport with the patient. Infection control is a priority when responding to skilled care facilities. Communicable diseases including methicillin-resistant Staphylococcus aureus, or MRSA, vancomycin-resistant enterococci, or VRE, and Clostridium difficile, or C. diff, are common in extended care facilities, so proper PPE must be worn and careful cleaning and disinfection should be completed after transport. This brings us to the end of this video. If you have questions about the material covered in this session, please consult your EMT textbook. Thanks so much for watching.